always a pleasure to be able to share my experience on my work in a place where very close to my heart because of my study past as well as work experience, including with Ibu Ade. The arch project that I will share with you this afternoon is actually funded by Bill and Melinda Gates Foundation. It is implemented in 5 countries aside from Indonesia. So currently the Arch project is on the 3rd stage, for each stage being a 3 years project. Indonesia was included at the 2nd stage, along with Cambodia, Nepal, Senegal, Tanzania, and Indonesia. And because Helen Keller International, as an international organization mandated under MOU with the government of Indonesia, particularly with Ministry of Health, our work in Indonesia was decided, or where we work, were decided by the Ministry of Health. So we are mandated by the Ministry of Health to work in Bandung for this project because of some consideration due to the nature of the health prevalence and particularly nutrition status at the moment at the beginning of our project. So it is decided that Bandung will be a perfect fit because it is an urban setting, one of the top 5 most populated cities in Indonesia, very close to Jakarta, where Jakarta itself, in comparison to population, almost as equal to one of the countries, to the other 5 countries. So Jakarta was not selected, hence Bandung was selected for the site of our project. There are 2 main activities that we did under the assessment for our project. The first being, actually the first one was that we conducted was the point of sale assessment. But this assessment was to support assessment to caregiver, which we conducted in order to be able to capture the situation of feeding pattern, particular consumptions of commercial products, and exposures of mothers to promotion of certain food categories. And before I begin, the ARCH project itself for the assessment was based on WHO UN UNICEF guidelines named the NET code. So the NET code was developed in 2014 in order to monitor the marketing of breast milk substitute. So this protocol was an enhancement from the, if any of you ever heard IGDM protocol, the publication was based on that. So NET code was an enhancement from the IGDM protocol. And why this protocol was issued by WHO and UNICEF, it is aimed to help countries to monitor the implementation of the code and enforce countries to follow the code in their each country laws. But what is the code? Any of you are familiar with breastfeeding advocacies? Somebody would, those who are working here. Well, actually there are 2 colleagues in the front who are very familiar. They will be able to help you explain. So there is what is called the International Code of Breast Milk Substitute, or commonly known as the code. And this code was issued by WHO in 1981 with the aim to ensure that breastfeeding is protected while marketing of breast milk substitute should be controlled in a way, particularly through making sure that these activities are very well controlled, or countries who upheld the code will follow the implementation of these rules. And so what we did for our project was to assess the situation, particularly in Indonesia, but through assessment in one site, in one city, in Bandung, using the protocol that was, I showed earlier, the net code, to learn how the implementation of the international code occurs in Indonesia. And the three categories of interest for the products that we want to monitor, so there's the breast milk substitute category, with each three different categories under the definition. Commercially produced complementary food, with the different categories under these categories of commercial food, or for Indonesia we know MPASI. And the third category is for commercial snack foods, or any snacks that is produced for general consumption but consumed by young children, commonly consumed by young children. What we did was, for the caregiver study assessment, we tried to capture the situation of infant and young children feeding practice in Bandung City. But of course, in order to capture a city practice, a large sample will be needed if we use the community cluster. Therefore, using the netcode as guidance, selection of samples or subjects were used. We used the health facilities as sites to recruit the mothers. How the health facilities were selected, there's quite a detailed instruction in the under netcode on how we can select what kind of health facilities that will help us be able to get the most optimum magnitude or sample for representation of the population that we want to select. So overall in Bandung, through some preliminary data collection, we've gathered that there are 60 health facilities providing child health service, and it is divided into public and private facilities. And so they are following the guidance of netcode. We ended up with 24 facilities selected to recruit the mothers sampled for the caregiver study. Now, before we conduct the caregiver study, we conducted what is called the point of sale study. So we went to stores. According to the netcode, we should select large and small stores to sample and collect the information that we needed. For the large stores, the netcode's guidance is to have purposive selection. And given our Bandung is almost similar like Jakarta, there are a lot of branches or brands or chains of stores, either hypermarkets, supermarkets. We had consultation. We conducted a focus group discussion with some experts from the field of infant and child feeding in Bandung to be able to gain some information in helping us decide which stores or which brand stores that would fit the most would help us gather the most information regarding the three categories of food that I showed you earlier. For the small stores, Netcode provided guidance that we should select 33 small stores, and the selection of the small stores were based on proximity of public health facilities. We identified in Bandung, we identified 33 health facilities. Interestingly, there are 30 UPT, Puskesmas, the primary health care center that provided the MTBS, the integrated child service, and there's also 3 public hospital that provided focused child health service. So overall, we had 33 health facilities identified, and then we tried to, using the Google Maps and Google Street View, we determined 4 small stores that are located in close proximity of those 33 health facilities. And before we conduct the point of sale assessment or the study, we also developed a list of products. So to recall, there are 3 categories that we wanted to observe. Yeah, first is the BMS, second is the commercially produced complementary food, and the third is the commercial snack foods. So we developed a list of the first 2 categories, the BMS and the commercially produced complementary foods, the MPAC. We made a list after consultation with BPOM, the Indonesian FDA, and we conducted systematic review for both the national registry as well as Google search of the producers, manufacturers, home pages, online shops, and so on. So we ended up with a list, and then we also did some scoping or store visits, both in Jakarta and in Bandung, to cross-check whether our lists are indeed can be implemented for our assessment and fits with the situation in the field. For the third category, commercial snacks, we did not make a list. So the aim was not to cross-check with the situation that is on the national registry, because snacks are very, very wide. There's a very wide range of variety for snacks in Indonesia. So we did not make a list. And during the recollection, we moved around in the stores to be able to cross-check for availability of these 2 categories, and also we document the promotions. As you can see, this was conducted in a retail. This was in the supermarket, Bandung, famous in Bandung, and this is typical warung, small kiosk. The type of promotions that we documented from each stores. So we made some categories, mainly the price-related promotion, and there are subcategories, display, and so on. If there are new or if there are ambiguous category that we have not determined, it will fall into other until after the data collection, we will have a discussion between our team to decide whether the ambiguous category is indeed actually can fall into the other 7 categories or fits into the other category. Since we also try to capture snack promotion that targets child or caregiver, so we particularly from the snacks, so from the category 3, from the snacks that are produced for public consumption but commonly consumed by young children. So from the photos that we gather, overall we captured 2,251 photos of promotions. Then those photos were assessed against a list of these seven categories or seven criteria to decide whether any of those photos or those promotions fits with any of these categories. The criteria was determined using literature reviews. So we reviewed several literature that focused on promotion targeting young children or caregiver of young children, and using their operational definitions or their result, we decided that these seven criteria will be able to capture what the information that we need to determine whether the promotions that from the 2,251 that we capture, whether they are indeed child targeted or caregiver targeted or both. And so the result. So it's supposedly a qualitative study. What are the numbers? So we using the information we gather from the point of sale assessment, we are able to have some data, for example, like this, proportion of promotion for VMS based on the categories, and then also still for VMS, whether what type of age group are do each of the promotion fall into. For the commercially produced food, what subcategories were found from the point of sales assessment. This is also based on the proportion based on the categories. For the snacks, we were able to gather information based on the stores, number of stores, proportion of subcategories of the snacks that was found in the stores, and also proportion of those promotions that are mostly found. So we, at the end of the day, although our activities were mostly qualitative, why do we quantify? Well, its aim is not to focus on the magnitude. You will see that by semi-quantifying these findings, we are able to make a decision to look deeper into categories that have a significant number of proportion to be able for us to decide we want to focus more or extract more information from those categories. And this is very useful, particularly when we move into the next step of the assessment, which is the caregiver study. Okay. So still, from the point of sale, what the type of promotions that we were able to capture were then quantified, such as these. For the child and caregiver targeted criteria that you've seen the diagram before, you can see that we found that there's a significant number of promotions that are targeted to children, either using cartoons or gifts, while promotions that are targeted to caregivers mostly use emotional cue or using putting words in their products or their claims like babies and so on, or put some health claims that leads to caregivers, parents, or whoever who come to the stores with young children think that those snacks are indeed suitable for the young children, to be consumed by young children. And using those information that we gather from the point of sale, we then were able to develop further list of or questionnaire or guidance for the caregiver study. As you can see, for example, here in the questionnaire for the caregiver study to understand consumption of breast milk substitute or recommendation of breast milk substitute by health professional, then we are able to list some brands that are found in the stores during the point of sale, and this will help our enumerators to provide a quicker entry during interview on the caregiver study. For the information are also useful to be added as probes or subcategories for the recall, during recall of consumptions of snacks, and also to help provide list of prompts to our enumerators in deciding food categories. These are also a list that you can see. These prompts that we put in the questionnaire guidelines or questionnaire manual for data collector, for our enumerator. We were able to look into the data that we collected from the point of sale a bit deeper to be able to put some brands and subcategories to help the enumerators understand when the caregiver or the mothers mention something about the foods consumed or the snacks or the complementary foods consumed by their children. What was the product meant by the mothers? So we were able to put the prompts here to help the data collector and enumerators to be able to enter the answers or responses quicker. Another use of the information we captured from the point of sale was that we know what are the foods that mostly consumed or consumed more by children in Bandung under our study subjects, so that we were able to see, to then extract the products to look at their nutrition values. We already made a presentation, made a publication, aiming at focusing at the iron values of commercially produced complementary food. So there is already a paper issued on Maternal and Child Nutrition Journal, focusing on iron values of commercially produced complementary foods and kreasi buatan pabrik which we found in Bandung City. The results are quite interesting. We also were able to capture information on added sugar from growing up milk, such as like this. As you can see, the Codex regulation is that Codex have a very strict regulation regarding the use of added sugar in growing up milk. So using the information we captured from the point of sale, we were able to look deeper into the contents of the growing up milks that we found common during the point of sale, and see that there are indeed actually a lot of categories of added sugar in growing up milks that we found during data collection. So these are the two publications that we made based on the two studies from the caregiver and point of sale studies in Bandung. And if anyone is interested, we can share with the documents or the links with the organizer. Thank you very much.